This is a study for Daniel L. To review. This is obviously a post-scan that was done on 4/13/2022. It's going to start off with the obvious. So obviously we see here disc replacement at 3/4, skipped 4/5, and ACDF down below. What's the obvious signs of further problems that can cause symptoms? The first thing we see with this could be segment disease from the fusion, and I'm betting that it's not, that this is there before, that this disc here that they put the ADR at, that there was a problem already at C2, C3, only because if this was fused, then there would be excessive movement at C2, 3. But because C2, 3, 4, and 5 have free-floating ability, anatomically speaking, so this, for the patient, this being locked up, it could cause, obviously, problems that are segmented upward. But the significance of this space here, so if I take a look at, I'm not going to count the backside calcification here, and let's just zoom in a lot more so we can get detailed, and I'm going to be very, very kind here, and what I mean by kind being making it extremely accurate. So you have anthrolisthesis. This is a arrow. So you have a forward head overhang, forward anterior overhang of 3.79 millimeters. That's very large and comes with a lot of symptoms, especially being with C2. The larger aspects is that what happens on digital motion x-ray, what happens when this patient looks down versus looks up. This looking up will obviously slide back probably to the correct position, but looking down, would it get worse? Big question. Surprising how good the space is between C2 and 3. That's actually really good. It's hard to judge. I'll have to skim through this to see whether or not did this ADR slip forward. This is pretty much done correctly here. Okay, so what we're looking at right now, this would be your big snapshot there. Anthrolisthesis, C2, 3. I don't think I can I type in this thing? I've not typed in this thing yet. Okay, next sign. I'm going to move this down, increase, and this, go to length, but we're not going to be using the length tool. So here, get rid of that, is the V sign, which is a transverse occipital ligament, which you normally don't find in too many anatomy books. So the ligament, the transverse ligament, is a band that wraps from the sides of C1 and comes around C2 and hugs it right here. It's a very, very strong ligament, but there's actually two sections of it. You have the lower transverse, and you have an upper occipital transverse. That's usually what creates this V sign. And so to bring this up, this is Dr. Centeno, who actually tries to pair this with orthobiologics. He's the leader in the world of orthobiologics, and he had a segment on the transverse ligament, and he does reference that ligament. In fact, it's where I learned it from. And I've actually sent in that to fix it in certain anatomy applications. So this V sign actually looks exactly like mine, and you can see this length, and we'll just go a little perpendicular, which is right at that pathological 3 millimeters part, and then you go down to 0. So you're close to that 3 millimeters. All right, so there is another snapshot here. I'm going to do this. So if I want to get really perfect, you're at 2.75, and then we can see that tapering going down. So right here is another snapshot that I would show. This is, see, pencil. So this is A, D, I. It's an atlantodental interval. That's that space. And this is anthrolesthesis. Anthro. Okay, now let's look at, I can already see the brainstem here, and it's close. How can I show you this? I can do a little bit of that. So you can see right here, this sliver here, and then this tissue. So this is what likely is a pannus. A pannus is, I should probably pull up a Word document so I can actually type you what's going on here. I should probably take these links. Alright, so I figured I'm going to just take the snapshots while I'm at it. So I redid this. It's a little bit lesser, so it's about 2 millimeters, which is pretty much equal to mine. And you have 3.3 on the anthrolesthesis, and so that will look like this as far as logging that image. So let's cancel that, and now let's take a look at this thicker tissue here, which is what they refer to as a pannus. So I'm going to do a couple things here. So this is a grab Oaks measurement, which we take from the dura, which is right there, and it's pretty big. So it's possibly at that so 9 millimeters is you draw the line at 9 millimeters. So this thick tissue band here, I would have to see an MRI, so it could be, well, this could be dead on, because right here, the darker portion of this is your spinal fluid, the darker inside is your brainstem, and then white here, the lighter dark is cerebral spinal fluid. So this is the grab Oaks. Now, depending on who does it, some actually do it right here. So if I do it, usually it's at the outer central cortex of this bone here called the clivus. And if I do that, we can make you just on the pathological. And so you and I are very close together on the same exact problem at the occiput. My current arrow is damage here. This is where a lot of crunching, sliding, grinding noises will occur. What are the other symptoms that usually follow is ear popping noises, crunching noises, base of your eyes hurting, pain right around here on the sides of the head. So right here, we're going to snapshot this. Actually, you know what? I'm going to do all of them in one shot. So let's just take a look at your angle. Bring this down right to that dot, since that is the central portion, and I can actually make edits. This is already not looking like a good number. Get out of here. So I'm going to actually follow the dural path. What I mean by is I'm following the front of the dura and following your brainstem. Normally with this axial angle view. Okay, I'm going to move this so I can actually function. keep this guy here. And what I'm going to do, because CAT scans are slightly off with what you're trying to look at, so I can get that guy right back here. All right, so what are we looking at? What does grab oak's measurement actually mean? All right, this is where I was, and this is where it goes. Put this guy right on that plus. And now you can see what happens is that you've got a lot of soft tissue here bulbing out. So I'm following the path of the dura, which is why MRIs are slightly better, but it's still following the same angle of that bone. So 136, we got grab oaks of, I gotta move this over here. I don't see any massive occipital movement, so we're gonna actually take a look at this number here and this number here. This is called the Powers ratio. And basically you do not want this number to be 1. So we take the 3 divided by 4.19, which is probably going to be in your 7s. So this number is fine. This is just where the skull is in relationship to where the brainstem's coming out, and you can just tell by eyeballing this. I didn't have to do this number. I could have just told you that that number was fine. So, okay, so now that that's logged, now we're going to take a look at the relationship of your skull to C1. I'm sorry, your skull to C2. So I'm going to take this and copy this since it's already there at the base. Bring it right out to here, and then we're going to take a look at that soft tissue. Now this, it's normally looking for what C2 is doing to the brainstem, as well as the C2's relationship with the skull. So it's basically some people's C2s retroflex backwards and they press into the brainstem, and that's where this pannus, this swelling, can happen. And that can also add more tissue here, and it presses into that, and therefore you also get what we see here is a low axial angle. This number should be in the mean of like 145 to 1, well, not the mean is 140, the mean is 150. So the lowest is 145, and usually once you start dropping underneath 145, then it's just a sign that something's going on, but does not mean there's a problem. So this next number is one of the Harris measurement lines, so I'm going to bring another line here. Looks like we're playing some sort of weird game. This should be under 10, and so we have BAI. I already did the ADI, which I might as well put it in there anyway, which is, I think it was roughly around 205, something of that nature. So we'll put that there, and that's about that. So I'm just going to put a little measurement right here also, and I'm just checking the ligament. Let me pause and I'll show you what I'm looking at. So you'll see this is where your brainstem is. So this is that transverse ligament that I was referencing, but I should have cut it in half to reference both of them. That was before I knew about the separation. And then you get, there's the V sign is actually in here, and it's not, obviously not at the top. It should not go all the way down. So there would be that right here, this band, this cruciate longitudinal ligament right here is kind of like the knee ACL, but this is the cruciate ligament of the skull that wraps around C2 and goes down, and then becomes that longitudinal ligament that goes all the way down your spine. So that goes around the transverse. So now you have this double band, and then there's other tissue. So this thickens up. There's nothing else for it to go other than backwards into the brainstem. So we come back down to here, here is, let me see, that's your Grab Oaks one. I'm going to put that one there. This one is there. All right, so you have this about, well, this is probably an outer shade of the, could be just calcification buildup, or because that white signal should be more bone. So I'm just going to put this right about here. And so that's about the length. There is nothing that says what's pathological in regards to this, but that is pretty thick. An MRI will reveal this a lot clearer. And so that would be the next thing to get done. All right, and the final one, which is nothing major because I can already see that it's not a problem. Bring this guy there, and this is the BDI, which needs to be also under 10. All right, so I got some measurements here. I'll put this there, put this there. This is Grab Oaks. I'll put this there. This is going to be, I'm going to call that the cruciate ligament measurement. This should be up here, and then we got that. And I can grab the calculator just to show 3 divided by 419 equals, and I'm going to print this. So this will be another thing to put into the document. I don't need all of that. And down. All right, so let's pause. Okay, moving on, I'm going to get rid of all these numbers here. It will let me. Shift delete. Alright, so we're going to now take a look at the sides facet joints, which I can show you where I'm actually looking. If you have a coronal view. No, yes you do. Alright, so we're going to come into here, and you can already see rotation right here. You can see the difference of deviation, which I already suspected was something was rotated. So as you'll see, as I'm moving around here, this is where we're going to be looking. So this is your, if I just bring this up for a, no, I'm not going to bring it up. So this is your right side, so opposite. So if you're looking at if you're looking at me, at the screen, right side's here, left side's here. So something that's common, and I think you and I have a similar problem. So you can see this facet joint here. This is C1, C2, C1, C2. So ignore the measurements actually. So you can see how these two line up right here. But we go to the other side. So this is now your left side. You can see what's going on as well here. So you have a, God, you're my twin. This is exactly what I have going on. So this, I'm curious if you have clunking noise around this area, clunking when you ever lay over a rolled towel, relax and get up, or even just laying over something anyway. So this is likely a rotation. So how we're going to find out, we're going to come over here and we're going to look at, zoom out. Of course, they chop the head off. I can't do this. That's what drives me nuts. Let me see if did they chop it all? Yes, they did. Go figure. They cut the face off because I like to try to find out exactly where center is. So here I'm going to take a guess at it right now. So here's the styloids, and if I were to just judge it based on if this is center, so I'm going to create a skull angle of where your skull is facing based on these numbers. So if I can get this right to a 90 degree. Alright, so now I can copy this. Now this does not denote a lot of stuff. So we're going to look at C1 and see if C1's facing in the same direction. Let me get rid of this. I do not want that there. Now C1, I don't normally like to use the foramen, but I just do that as a starting point. Ooh, look at that, almost got a 90-degree right away. I'd be curious if you have any rumbling noise in your right ear. So I'm just judging to see whether or not this lines up. And so here's where I would say you have a C1 skull, slight C1 skull rotation, but this could be just how you're laying in the machine. So what's the number? So it's just about a 1.9 rotation, which is nothing to even complain about. Alright, moving on, still at 20 minutes so far. Now we're going to come down to C2, which is actually looking pretty straight. Well, maybe not. I mean, a lot of posterior portions of the spine can actually be pretty mangled looking. So, so if I'm looking at C2 and just taking a stab at it, this is not me being too meticulous. Yeah, so let me just go back up to C1. Which way was C1 going? I'm going to bring in C1 here, copy. See that this is where, if these numbers are correct, is that I don't like to measure without the full entire spine, because without the whole head. This over here that I was referencing, this slight overhang, you know, as we taper, things start small, and the more you go, the more it gets wider. So if the skull is here, this is what I call the Indian burn of the head. C1 is going to the right, and C2 is going to the left. And you got the skull trying to sit in the middle of this. And now this is, of course, hold on, let me make sure which one I got here. This is C1. Let me get that right back down there. I'm putting them together based on this. So, you know what, I want to be meticulous, pausing. So now that I zoomed in, the number is slightly bigger. So, so this is the skull line, and this is C1. So skull, C1, and green is C2. So between C1 and C2, you have about a 4-degree rotation with the skull in the middle. So, so if C1's going one way, and you got to see that I call that the Indian burn again, because what normally happens is this is a very hidden ligament that people do not take in consideration, is the posterior membrane that comes right here. Is the atlanto-occipital membrane, which wraps around C1, and if I bring in, let me just take a quick scroll through here, make sure nothing else is going on. Okay. Nerve root's good, nerve root's good, nerve root's good. Okay, so there's nothing there. Now the styloids, you can see a difference between this, just to reference. The difference between this is that this side has where the jugular vein comes through, and if the jugular vein crosses this path in between, which it normally does, so there's lesser space here than there is here. So if I kill that, and normally you want more than 7 millimeters between this, so you're just at that range. And then this guy, you can see how far away he is. So he's roughly about 1 cm. Does that cause a problem? It all depends on what an angiogram would look like, and that's what you would want to get. If there was blood pressure problems in your head, whooshing noises, head pressure, pulsatile tinnitus, things like that would warrant a CT angiogram. Okay, so there's something I want to also what I'm looking at here. I just want to see if it's okay. Now, what I was talking about before, the posterior membrane, I'm going to change this. There we go. A little bit more bone function. So the posterior membrane comes here and wraps to the posterior side back, posterior back to C1. And when I come around, you'll see these little calcific spots right here, and that could be the muscle, the ligament attachment to the posterior membrane. And you can see it's going. So let's just let you see what side we're talking about. We want to grab this guy, keep him there, and so you can see on your left side, this is where this slight calcific spot comes in. Arrow. And let's get all the way up here. I don't think you're really going to get to see these normally. So we're looking at right around this part right there. So obviously it's a white signal, but I can't judge that. Obviously it's just judged on this sagittal view. So and because obviously in regards to symmetry, you don't see it on this side. You see a little bit right there, but not as significant as this. So let me arrow this guy and arrow that guy. So this is alright, so that's that P-A-O-M. I can spell with my mouse. Okay. So the question, of course, is do these things actually mean anything? Now, this is the next portion of the view here. This is not bad. So this is a matter of where the middle of C2, and you can see this, a little calcific spot, but again, you could be slightly turned. So these numbers are not the best. So what I normally do is I dance around to see what's going on. Now this could be where your damage is to the transverse, or no, it wouldn't be the transverse. This would be more right around here where you would see it. It might not be anything major, but even this slight deviation is not really much to talk about. It's more of like over time when you have one deviation to another deviation to another, and then you have these little one-off problems that cause multiple symptoms. So let me pause, and we'll finalize this with just looking at the skull. Well, we'll look at all the facet joints here. So these joints are nice, clear. The question is whether there's a fusion. You need an MRI to see if there is any. And then we're going to bring down here. So you can see, obviously, if where C2 is not exactly in line with the skull properly, so there's obviously some tilting going on. What that means, trying to see if there's any. See, these are the points where you want them to line up, but you can see that C1 is kind of slightly lateral of C2, but it might be more of those rotations that we were talking about before. You can kind of just almost eyeball, you can understand that the relationship between C2 and C3 is not good. So C3 being set back, as I mentioned before. Other than that, sign of any hardware damage. And you see the joints, clear space, a little buff calcification there, but it's opened up. I'd actually be curious of what the CT scan looked prior to see whether or not is this salvageable. So three-dimensionally, these are the styloids, those are the tooth-like structures. So I can actually look at this perp with us here, and I don't know, did that load properly? Yes, it did. I'm going to pause so I can clean it up. Alright, there's probably not going to be too much to talk about here, but you can see there's some degeneration on this facet here. You don't normally use three-dimensional anywhere to diagnose a lot. You use it to know where to look in two-dimensional. So if there's something that kind of rings out here, then I go back to two-dimensional and I come down and I start looking for, let's say like that was at C23. So I would look for, see if there's that calcification that I saw, and see if there's anything blocking nerve paths. So which I don't see. So so here's the styloid, as I was mentioning here. You got the jugular vein that comes right through here. Sometimes that jugular vein crimps it crimps in the front. So depending on where your jugular vein is, so we can actually look at where your foramen hole is right here. That's where the jugular comes out, and it's probably I gotta see how large that is because it might be eroded. So we'll look at that from the top. But other than that, this is where we were talking about the calcifications that happen right there. These are obviously from some sort of damage. You can see how much more space is on the left, and not too mangled in there. And here is that peculiar spot here. Let me pause for a second. Okay, so someone might call this a condyle fragment, but this could be damage to the capsule ligament comes around all the facet joints. Every facet joint has a capsule. It'd be a capsule here, capsule here. Now this could have been a massive damage to that ligament, that when ligaments start to calcify and it starts to build right on top of that. I'd imagine maybe this is the side, your right side clunking, if you dealt with clunking. And if you look up, you would get jammed on the right side. You would look up and you would feel just rigid stiffness. I'd like to actually know if that's true. That'd be very interesting to know how this affects you, because that looks like that would cause you some major inability to look up. So I'm assuming if you look up and you lean more towards the left side, your back of your left side would go up, and your right side would compensate by going forward. So other than that, I just wanted to take a look at the foramen. Okay, you can see right here, these are the jugular foramen. The right side is a little bit bigger. Maybe. Could be just the way I'm angling the screen. Alright, I'm going to say no. I'm just going to ignore that. Frankly, I can just I can do another. So you can see how it helps us to look. I'm not going to say a bunch of jargon right now. pause. Not going to majorly ignore it. So this is so left side versus right side. So here's where the jugular foramen comes out and then goes down. So this is where that's you got the transverse this transverse sinus vein that comes out around into the sigmoid and then down and becomes that internal jugular vein. And so it's not this is nothing to write home about. So you got 7-7. When you come over this side, you got a lot more of the millimeters happening here on the right side, and you can see where we're looking at. And the few more millimeters usually would tell you that there's more pressure inside of that jugular vein and tends to erode inside. It might be over time something can continue on. It's just trying to do its job and it can't, and so the body has amazing ways of doing things. All right, so I'm going to pause real quick. Okay, the final thing I wanted to look at was that right side. Here is that what we looked at three-dimensionally. See, that's the 400. This is the 400, and I'm going to pause. Oops. Escape. All right, so this is what we were looking at here. All right, let me pull this back. I'm going to get an arrow on this so that way we can show what we're looking at. This is obviously right side, right, and we're going to put this guy down right here, and then I can actually pull in arrows, right side, and pull him back up, and then I can get a screenshot of this. So this is another interesting osteophyte that's growing, but you can see there's space between that. Of course, you have the high resolution. So as I pull it away, it doesn't seem to be touching, which tells me that it's probably something that grew out from the condyle ligament, the capsule ligament. Could it be the posterior membrane? I don't know if it's going to go that deep or grow inward, or this is just some other idiopathic thing that's going on. Okay, so I think that's as far as I can go for now at 38 minutes. A lot of information there, and definitely a lot of things that can cause a lot of symptoms.